Thanks for listening to this video. My name's Dr. Dale Hanson and I'm a Rural Generalist Training Advisor within the Queensland Rural Generalist Pathway. And I was the lead researcher in the peer study, the Prevocational Integrated Extended Rural Clinical Experience. Quite a mouthful, but essentially descriptive of what the program was. I think it's worth beginning by explaining a couple of key concepts. And the concept of rural generalism began in Queensland with a crisis meeting of senior rural doctors in Roer, Western Queensland, on the 1st of October 2005, when they discussed the problem of the lack of medical graduates entering rural medicine and the devastating effect that might have on provision of rural services in Queensland. And they came up with the Roer Agreement, and the essence of the Roer Agreement is perhaps if we created a pathway of training that led to a well-recognised professional outcome that was appropriately remunerated, and we provided a supportive environment for trainees, then they may wish to engage in training for rural medicine. And so in 2007, the Queensland Rural Generalist Pathway was established, and it was built on 4 pillars. Appropriate recognition of the professional of rural generalism, appropriate pay, a supportive pathway, and finally workforce redesign. And the program of training was in 4 phases. Students entered the Rural Generalist Pathway from the final year of medicine. And then in their pre-vocational years, year 1 and 2 postgraduate, they had general training, which in the Rural Generalist Pathway included terms in anaesthetics, O&G and paediatrics. In PGY3, they had advanced training in a special area of expertise. And finally, in PGY4 and 5, they had vocational training in rural hospitals or a rural general practice. And the program was in fact very successful, as epitomised in this picture, which shows a caesarean section being performed by 3 senior trainees of the Queensland Rural Generalist Pathway. And it signified the arrival of the next generation of rural doctors. And very pleased with this outcome, the then Health Minister, Laura Springboard, announced a doubling of the intake of the Queensland Rural Generalist Pathway in 2012. And while that is a wonderful opportunity, it also brought some special challenges for us to address. It's worth taking a moment also to explain the concept of rural generalism. And while Queensland Health created its own definition of rural generalism, industrial definition, so that the trainees could be remunerated at the appropriate level, once this became an Australian-wide concept, the definition of a rural generalist needed to be renegotiated. And in February 2018, representatives of the 2 colleges that train people in rural generalism, which is the Australian College of Rural and Remote Medicine and the Royal Australian College of General Practitioners, met in the Colin Grove Homestead in Angaston, South Australia, facilitated by the Rural Health Commissioner, Paul Worley, to come up with the definition. And this is Colin Grove. If you like your South Australian wines, and particularly like Yalumba wine, it comes from Colin Grove. So they came up with this definition. A rural generalist is a medical practitioner who works in rural and remote communities, and they have 3 areas of expertise: comprehensive general practice, emergency care, and an area of specialist care that they provide that's necessary in the rural hospital in which they work. And rural generalists work both in hospitals and community settings. So having explained all that, let's talk about the PEERS program. The Rural Generalist Pathway was confronted with the issue of how to expand the training capacity. And 2 ideas were mooted and trialled. And one was having shorter placements at rural hospitals, and the other was the PEERS program. So Pierce was a 15-week authentic integrated rural placement in anaesthetics, O&G and paediatrics in the everyday practice of a rural hospital. So it was learning those skills in the context, the normal practice of a rural hospital, learning the skills the way they would be used in the long run. So what did the trainees say? And really they said that both experiences, we were comparing the experiences of a rural hospital with that provided in a regional hospital. And the trainees basically said that both experiences were valuable from their point of view. And they didn't want to do one or the other, or one as a substitution of the other. Rather, they both thought that they had important learning opportunities. And when you think about it, they're actually saying that something that is quite profound, because medical education's tended to be built on a one-size-fits-all, that there is a curriculum that needs to be met, and that curriculum can be met in many different environments. And the trainees were saying, actually, different contexts have different learning advantages, and then the objective is to capitalise on the learning opportunities in that environment. And they identified a number of important learning opportunities that were particular strengths of the rural placements. And interestingly, they're the same learning mechanisms that were identified in undergraduate rural placements. Continuity of care, continuity of supervision, participative hands-on learning, real clinical responsibility for real work, broad clinical exposure, but it does need to be a sufficient duration, and it does suit different trainees. Those trainees that have an active learning style tend to get more out of the term. And these learning mechanisms were focused by the learning context on the outcomes that we wanted. And it was the learning context that was the major difference that the trainees identified. And they were about professional identity formation, role models, communities of practice, and a supportive administrative environment for rural training. So Pierce trainees really described a type of learning that was about who they were. It was about living to become. You're seeing the people are living the job and seeing them enjoying the job. You're being immersed in a community where you're living like it will be. And this was quite different from what they were learning in the regional hospitals, which was, we're learning practical skills and that's very useful and we want that too. But it was more about not their what they could learn, not their contribution to a rural community. And finally, in internship, whether it be in the terms in anaesthetics, O&G, or core training, all interns have to do medicine, surgery and emergency medicine. Their experiences, they describe, were much more passive. I felt like a student again, sitting on the sidelines watching. You absorb things peripherally, you don't really get to do them. So that was more about learning to work, as the interns were sort of outside observers, documenting what was happening but not actively involved in the decision-making process. So the key finding here is that professional identity formation is very important, and that is learnt in the context that you are going to practice in the long run. So some people propose that there is a fifth level to Miller's pyramid, which is it's about who I am. A rural doctor is not only has different skills and different knowledge, but they are a different type of medical practitioner. But I think it's best if I give our trainees the final word. And this is their comment. Pierce was excellent for hands-on experience and excellent for knowing what you want to do with your career. I came away knowing absolutely that I wanted to be a rural generalist. Thank you for your interest in the Pierce study.